I'm Nadja Swart for BizNews.com, and with me today is Dr. David Erritzoe, clinical senior lecturer in general psychiatry in Centers for Neuropsychopharmacology and Psychedelic Research at Imperial College London. We've struggled to pin this interview down, so it's great that I'm finally speaking to you. Thank you for your time.
Thanks a lot for having me. Yeah, sorry for the difficulties.
No worries. You've landed in a very unique niche. Well, how did you get there?
So I guess the main topic I think for what you're going to ask is about the PET imaging work with serotonin,
Yeah.
and I ended up being trained in PET imaging. As many things, a little bit randomly, I went to the US and uh, when I just finished medical school and ended up in a fantastic group at Columbia University for a year with funding from back home, and I then got trained in doing these molecular scans, measuring receptor systems, and then I went back to Denmark, where I'm originally from, and did my PhD, same topic, and did apply these methods to study the effects of recreational use of MDMA and psychedelics. And that has then brought me later on in my postdoc, later career, into um, studying psychedelics, so brain mechanisms and therapeutic implications of psychedelics. But then at the same time, I've been lucky to sometimes be involved in some PET work. It's difficult because it's so quite expensive, difficult to get funding to do PET work. I mean,
What exactly is
um,
PET work?
yeah,
What does
so
it
so
entail?
yeah, so PET is a radioactive molecular imaging techniques. It's basically the only way to access and measure, assess the brain pharmacology in the living human brain. So,
Mhm.
MRI is a
Yeah.
magnet, and there you can measure structure, you can measure um, blood flow, you can measure what is called bold response, so different sort of functions, activations in the brain, both during resting and also during different tasks. So but it's not very specific. It's not that it measures a specific system, a specific transmitter system, for instance.
Mhm.
And PET has that advantage that you basically can radio label very specific molecules, like think about a pharmaceutical and make it very, very specific to only one target, preferably. And then it needs to live up to different criteria in order to be a good radio tracer. It needs to have some
Mhm.
specific
Yeah.
kinetic and so on. Then you radio label that one, and then you infuse it into a vein, and then it travels over the blood brain barrier into the brain, and then it sort of fits like a hand in the glove to its target, which could be a receptor, a transporter, an enzyme, depending on what it is that you are injecting. And then you scan typically for an hour or 90 minutes. And often you need to take blood from an artery in order to collect arterial blood samples, a lot of them over time, so you can build a curve of input to the brain. So basically, what you take from the artery in the arm will represent the input into the brain, and that you use to quantify the target you're measuring. Then you can measure a density of that target, and so that's the PET method used in sort of brain science like this.
And I'm assuming that it also is done in with the intention to find out what medications work.
It can be used for different things. So let's say that you have a new medication and it's in drug development, and you in a way want to see what dose hits how many of the receptors, and is it actually going into the brain and actually hitting the receptors. That kind of what is called occupancy PET work can be done in drug development. Um, it's not that you can easily just radio label the actual pharmaceutical you want to test, but you can put it up against different radio label targets with the PET, and then you can measure occupancy, for instance. That's one thing that is sometimes used in drug development.
Referring to that study that you mentioned earlier, in July this year, the study led by Dr. Joanna Moncrieff found that there's no convincing evidence that depression is connected with low serotonin, let alone caused by it. And as you're well aware, I'm sure it shook the field of psychiatry, and probably even more the millions of people that are taking antidepressants, particularly SSRIs. You've recently co-authored a paper which, in contrast, has found that brain serotonin release is reduced in the brains of patients with depression. What was the methodology and design of the study?
Yeah. So you're right. It's the first, it's sort of a decent attempt to measure this release directly. That's not necessarily the same as measuring extracellular levels in the brain of
Mhm.
serotonin. It because we are in a way manipulating the brain in order to be able to measure it. So therefore, the method is that you do a PET scan, a bit like what I explained
Mhm.
before. And it in this case, it was a PET radio tracer that was binding to the serotonin 2A receptor. So you have a range of receptors, 14 or something like that, in the serotonin system. This is one of them. It's mainly postsynaptic, and as postsynaptic is it's a lot in the cortex of the brain. And it obviously is an receptor of interest for me and others working in the field of psychedelics, because it's actually the same receptor that psychedelics, they stimulate that receptor and induce the psychedelic effects. However, so you can give that tracer, and then you can quantify the density of that receptor in the different cortical brain regions. And then what we do here when we want to measure a transmitter, so not just the receptor but the actual transmitter, then we need to manipulate the system. So you can either try to decrease the levels of serotonin or increase it, and then do another scan. And then the idea is that the difference in the serotonin available out in the synapse will then compete differently with the PET tracer sitting on the receptor. So if you do something that increases the levels of serotonin, you will then get less binding of the radio tracer in the second scan after you have done that, compared to the one done before, so the baseline. Then you can subtract the two scans and get a measure of the difference, which is then a measure of how much serotonin was released and competing with it. Or it could be that the serotonin that was released by the agent that you give. In this case, it was dexamphetamine, um, and it could lead to internalization of the receptors. But either or, there's an effect of the serotonin that you are then picking up by the second PET scan. So that's the concept, and it's the same principle that has been successfully used, I would say, in the dopamine field. So there you had PET radio tracers that have worked and behaved nicely for this to work. So therefore, a lot of studies, not a lot, but decent amount of studies have been done over the last decades, measuring dopamine release. So instead, then you use a dopamine tracer and you give something that releases dopamine. Actually, the same. Well, typically it has been methylphenidate or dexamphetamine, as we also used here.
What
Then you
class
have
of drug is it?
it's an amphetamine, so it's a stimulant. So it is a drug that can be prescribed in ADHD. It's not used that much, but it is safe to administer in studies,
Mhm.
and can be prescribed to patients also maybe with some sleep conditions. I've never prescribed dexamphetamine. It's a drug that can be lead to dependence, and also it's a tricky drug. But in a single dose like this, it's safe to use, and it has been used a lot in these molecular brain imaging studies.
Mhm.
And I think the weird thing about it here is that people will say, well, why did you use amphetamine? Amphetamine is a dopamine releaser, so you are
Mhm.
trying to measure serotonin release. Why use dopamine? And that is a good question. And the original plan was actually to use MDMA.
Mhm.
Another drug that would be great would be fenfluramine, but the issue is that fenfluramine is difficult, and the safety profile is not perfect, so it's difficult to use. MDMA might have a tiny bit of affinity, so ability to actually itself bind to the 2A receptor. That is going to confuse the results. So therefore, we started with amphetamine, because amphetamine, in addition to releasing dopamine, also releases actually quite a lot of serotonin. So therefore, And then you can say, oh, are you not then accidentally picking up the release of dopamine, because it does release more dopamine than serotonin, this drug, amphetamine. But the issue is that the dopamine wouldn't really bind to this serotonin 2A receptor. So therefore, it would still work if it releases enough serotonin, and it did. So we first validated that in healthy people to see whether it worked, and then we compared it. Then we did the same thing in people with depression, and what we found was a reduced release capacity, so a reduced release of serotonin with this method in the patients with depression. And it was a mix of patients with major depression, and Parkinson depression. So all had a major depressive episode. So that's why we refer to a major depressive episode as the group overall. So we compared these 17 patients to 20 healthy controls, and the controls, nicely, we could measure the release, but in the patients, they didn't really release overall. And so that's why the conclusion is what it is in this study, that there was reduced release.
Would it be valuable to try to do the PET scans on people with depression that are taking antidepressants to see whether or not there's a difference?
Um, so what probably would be valuable, I would say, put it the different way around. So critics, including ourselves, I mean, you're always trying to critique and look for holes in the cheese, limitations if in any kind of way of interpreting your own results and understanding them. So of course, antidepressant, if people are on antidepressant medications, that can affect everything in the serotonin system, because you're taking something that changes the levels extracellularly in the brain, that can affect receptor binding of the tracers that you're using. So I guess the cleanest study would be to have people who have never ever been taking antidepressants, and then do a study there. So this study was a mix. We didn't see difference between the people who had been treated in the past with antidepressant versus the ones who had never been. Nobody was treated currently with antidepressants. That's a good thing. If you did it with people who are currently on antidepressant, you wouldn't really know what is the effect of what. But what you could do in order to say, is this actually a real causal thing? Is this part of the etiology of the depression, so to speak? And different things would be logical next steps. One would be to look at people at high risk who yet haven't developed depression, to see how does that look, and therefore obviously also never have been treated. And another thing you could do is you need to repeat these studies. They are relatively small samples, which is always the case with a new method in PET. So it needs to be repeated, preferred by another group on another scanner and so on. And it could then be expanded, only focus on people who are maybe never been treated, even people who are at risk of depression. And then you could also treat people and see later on, how does that then affect the measures? Are you normalizing them? But again, having an antidepressant on board with this kind of measure is tricky. But all of that would be logical next steps for sure.
Critics have argued that the results are not robust and that the evidence presented is not proportional to the conclusions drawn. How do you respond to this?
I mean, I I'll just say that this is. I think it's actually. I think it's because of the Moncrieff, and I think that in a way there's some underlying debate and people disagreeing about how efficient antidepressants are and so on. And this study has nothing to do with that. It's has actually really nothing to do with it. It's just a basic science study trying to assess the brain biology in depression and understand that better. So you can't really conclude anything about antidepressant from this study, and has never been part of it. Whether we conclude too much, I mean, it is the first more direct assessment of serotonin in the brain. It just is, because it has been tried for decades to find the combination of a radio tracer with a pharmacological challenge that would work and it be able to pick up this release, and it just hasn't worked. And this method, therefore, is the first that where it worked, and the first time it has been applied in patients with depression, and the finding there is that reduction. And whether we are overstating it, that's basically just that is what the study shows. Those are the results. It's a conventional normal statistics, um, with a predefined hypothesis based on the serotonin hypothesis and all this more indirect evidence that Moncrieff and co-authors are challenging. But the hypothesis was built on that hypothesis, and about monoamine deficiency in depression, which is a pretty established hypothesis. And therefore this is what we thought we were gonna find, and it was what we were gonna find. And how strong is that? As I've already said, these kind of PET studies are not massive. They're very, very expensive. We actually have tried to make it bigger, but this is very conventional size for a PET study. The dopamine literature in schizophrenia, in addiction, similar methods, same kind of study sizes, but obviously you don't fully conclude much before you have different groups doing it over years. But it's still quite exciting when a new method is there, and it actually shows some results in the expected direction, maybe not to everybody's expected direction apparently in this debate, but nevertheless, how robust is it? The data is what it is. I mean, if you pull out several people in a small study, yeah, you'll find different results. But the thing is, what we did was there was one who was quite extreme in the depression group, so and that lived up to normal standard criteria for outlier. Then we took that person out. That person drove the results even further in the direction of the conclusion. So it's not that we took an outlier out that then made it made the results less in the concluded direction. And then you can keep on picking people out, and then at some point you won't find any statistically significant difference, obviously, but it's robust enough to carry the conclusion with the limitation that already sits in the paper. So I don't feel sort of wrong or bad about the paper or the way that it's being presented. I think it's absolutely defendable and fair enough.
Did you set out to do this study in response to Moncrieff's study?
That would have been impressive, to raise millions of pounds to do these PET scans within 2 months to get ethics approved. It takes years to do. The last scans were long gone. It has taken a long time to double check, reanalyze, and basically write the paper, submit it, reviewers. So all that was happening already when the Moncrieff came out. So it's completely random that their critical review in molecular psychiatry came out. In a way, I guess what it has done is that it has clearly, brought more focus to a paper like ours. Because of it has suddenly been reopened, that debate, and suddenly is a bit controversial. And to be honest, I welcome very critical eyes on science, also in the field that I myself work. I think it's very important. You can then argue whether their conclusions and their way of critically assessing all that literature is complete, and I would argue it's not. There are some issues, and they are being sort of in a way challenged, and which is complete normal and good scientific debate. When people quite strongly claim something, then they will be challenged, and then it's a debate, right? And here, I guess the question about how robust it is, it's a fine, meaningful challenge, and I'll say it is as robust as a data set of that size is. So it's not that anybody fully concluded that, oh, now we know that dopamine release is increased in schizophrenia after the first study. When you see a few studies, then you start becoming more certain, done by different centers and so on. So nobody would ever conclude that. What we can still conclude is the first more direct evidence in the direction supporting the original hypothesis of depression. That it is.
What I found quite interesting is that the study indicated that serotonin release capacity is a result of depression and not of antidepressant treatment.
It doesn't conclude it, but because you can't really conclude causality.
Mm-hmm.
But what you can say is that let's say that half of the patient had been already treated with the antidepressants, the other half hadn't, and the people who had been treated with antidepressants, they are the one driving the results. And then you would have to question, how is the finding actually, does it look like it's more an effect of the treatment, or do we think it's actually directly related to the condition itself? And here, when we looked at those two subgroups, they didn't differ in the results. So that doesn't point towards that what we are finding is a medication effect, right? But you would probably, it would be great to see a bigger study just with antidepressant free or even antidepressant naive patients. Obviously, that would make it stronger, if somebody did that, or we did that in the future.
Following the publication of Moncrieff's study, I spoke to Dr. Peter Bregan, and he said that the only chemical imbalances in the brain are put there as a result of the use of psychiatric medication. What's your take on that?
My take on that is that that's an extremely bold statement, and a statement I don't know. I don't think any colleagues I've met would ever make such a bold statement. So I've never met um, Peter. It's a very bold statement, and that basically means that he rules out that any findings in neuroscience and any mental health condition ever, um, that none of it is valid because it's all due to medication effects, or drug effects. If you think about addiction and recreational drugs or alcohol, um, and and that's actually why I mentioned this thing about medication naive.
Mhm.
Um,
What does medication naive mean?
so that people who have never been, a person with schizophrenia, a person with depression, um, who has never been treated with a medication, if you study those, or people who are at risk, who have again never been treated, that then obviously the evidence builds towards that it's not just what Peter Bregan is saying, that's an effect of medication. And but it's in a way, I think there's something healthy in the point he's making, and that
Mm,
is everybody should be very careful about concluding, um, if everything that has been studied is in people who have already been medicated, and you're measuring a system that the medication works in, then obviously medication could affect what you're measuring. Um, and an example is addiction literature. That's not in the medication, but people are obviously taking different compounds as part of the addiction, alcohol, stimulants, whatever. Um, they do impact on the dopamine system. So if you
mm,
are measuring the dopamine system with PET, for instance, and you are concluding that this is now a vulnerability marker, this is directly associated with the condition or the risk of becoming addicted to something, then that should, people should be very careful. Then you can then take maybe people who have other kind of more behavioral addictions, gambling,
mm,
other, and look
mm,
at those and see if the same picture is there. Then it probably isn't just an impact of the, that literature is, to his point, slightly blurry, and therefore caution should be made, by concluding on a field if all the research done there has been done in people who have been treated with medication. So it's a good point, but this thing about saying that it's all due to that, I would call extremely bold, to say the least. Yeah.
Well, then I'm going to give you another statement that he made that is next level bold.
Okay.
He said that at the heart of psychiatry, it's about damaging the brain.
Again, it's very bold, and to me a bit, too black and white. I, I as a psychiatrist, I think I have taken more people off or reduced medication than I have put people on. That doesn't mean that I think that they are doing only damage, or they are deeply problematic, or that they don't work at all.
Mm,
I think that everything we use in psychiatry, as in other fields of medication, have um, have side effects, and yes, there are some medications that actually have quite bad side effects, and also negative health and even shortening of life expectancy and so on when it comes to antipsychotics. So they are tricky compounds and they are not perfect. However, when people are really unwell and they respond to the medication, then they serve an important purpose. And if you claim that any medication in psychiatry it doesn't work, then the effect sizes overall in psychiatry and in those kind of medications are right in the middle of medicine. There are other fields of medicine that have lower effect sizes of the treatment used. So you could apply the same to the whole of medicine then, that medication are wrong. It's just wrong. You should never use medication. And again, I would say it starts becoming very black and white. I'm not claiming or blindly prescribing antidepressants in my practice. Right now, I'm just doing research, but um, um, because it's you have antidepressant when you talk about uh, depression. You also have talking therapies, and with a certain severity, then you should consider antidepressant. But I would say the psychology, the talking therapy, plays a really, really, really key role in my view on how to help people with mental health problems, including depression. Um, but it doesn't mean that there's absolutely no role for antidepressants in my eyes. I think that the data is there to support that it does have efficacy beyond placebo. It's not massive and magical for a lot of people. For some, it actually really does work.
Mm.
For a range, it works a bit, and for some, it doesn't. Maybe a third, it doesn't at all in treatment resistance. This method here is not in order to and this study is not to say, oh, here you go, that's why antidepressants are important. No, it's not. And actually, I would rather put it the other way around. The most interesting application in the future for this kind of method, as I see it, would be to take people um, and do a baseline before you start treating with this technique, and you could use the equivalent techniques for the other transmitter systems, and then you could start treating people, and then you could see whether there's a relationship between their sort of changes compared to a norm population in these measures and how they respond to the treatment. It might be that a person with depression, um, if you compare them to matched group of people without depression, that they release exactly the same, that person with depression.
Mm.
Then it could be that therefore a very serotonergic antidepressant medication is not what is needed. It should be another kind of medication, maybe more noradrenergic or so on. At least that is a very meaningful way of using these kind of methods to test why is it that some people don't respond or maybe respond better to another group that has a different pharmacology, works on another system. And it basically speaks back to that the etiology of depression is not just that there is a problems with serotonin. It's much more complex than that. There's different etiologies behind the syndrome of depression, but these methods are not there to support people being treated with a specific medication, but they are trying to understand who respond, how, and why, and they can help us understand that in a way hopefully will help people who are not responding to treatment, figuring out what then to do, or just understanding the biology of that better. That I do see significant value in, and so instead of just claiming that some of these bold statements.
About a month ago, I started researching akathisia, and it's frightening and makes one wonder whether what you're going through as a result of tapering off, especially the withdrawal akathisia, is then worth ever having been on it. What can you tell me about the prevalence? Is it very common? Like, how do you treat it?
So you're speaking about the sort of discontinuation syndrome, or so being tapered off antidepressant, and then people have unpleasant side effects, and what is the prevalence? How do you treat? So this, I to be honest, I haven't prepared talking about. I think that to some degree, psychiatry has been maybe somewhat arrogantly ignoring that this was a phenomenon, and it's becoming clearer that it is, and it is a separate thing from just having your depression coming back. can be really difficult to distinguish what is what. But I would say more and more data support what people are also explaining, that this is not just medicine. It is horrible to get off these medications. For some people, it's easier than others. Probably also depends on how long you've been on it. They might also differ. There are all these differences, and then not the least, how quick is it being done? And I think there is a move towards doing that much more gently and slow to avoid these states. So I think it's being recognized and acknowledged much better, which I think is also just respectful for patients who are experiencing this. And yeah, just sitting up on the high horse and saying no, it doesn't exist, or and refusing to call it, I don't know, dependence. I don't think it is for definition issues. It might not be exactly the same, but that doesn't mean that we can just label it as something that sounds much more benign. If it's a large group of people really struggling and suffering with that, then it needs to be taken very seriously and considered, and also in a way considered when you start people on antidepressant. However, if people are really, really, really struggling, I still see the value in, and I would do that, particularly if talking therapy is already in place and it's not enough, to then also try an antidepressant. However, you should always evaluate what you're doing as a medic in general, and see if you have prescribed something, you need to assess whether it works well enough, or whether it's therefore meaningful to stay on it, whether it should be stopped or changed.
Mm.
And sometimes people in medicine in general, but I think actually maybe in particular psychiatry, people do strand a bit on different medications that might not really work, might even give them side effects, those things. But that's what you know good medics, psychiatrists obviously are doing as well as they can, but these things should be evaluated over time, not just park somebody on a medication if it doesn't really work or give a lot of side effects.
Or if there is an alternative, first generation antipsychotics are the most related to bad akathisia. So, one would hope that other options with less of a chance of causing withdrawal akathisia are rather considered.
Yeah, I mean, not many people prescribe the first generation antipsychotics anymore. And you're right. That's mainly an issue with those extrapyramidal side effects coming from that type of antipsychotics. And then there are others, but then they have their problems, and metabolic syndrome, all these kind of things that are also very, very tricky. But I mean, now it's antipsychotics and their side effects, and then it's antidepressants and their discontinuation syndromes, and it's two different things, but they can all be extremely unpleasant. Obviously, there's no doubt about that.
So since 2009, you've been doing research of postdoc imaging research into the neurobiology of addiction and major depression. So, what exactly does postdoc imaging research entail, and why addiction and severe depression?
So postdoc is, I don't, yeah, that just refers to that I did it after my PhD, but my position has been different ones as gradually become older and further away from your PhD and more senior. So now it's a clinical senior lectureship, which is the same as associate professorship. So I've been, yeah, since my PhD, after I moved to the UK and worked at Imperial, been involved in a range of different studies. Some of them with PET. This is one example. And some of them with MRI, which I'm less of an expert in, and EEG as well. So different kinds of brain imaging, PET, positron emission tomography, as we have talked about, MRI, and also EEG. And we use that in order to try and understand the brain better, and also to understand drugs better and the mechanism of actions of different drugs, and particularly drugs that are on their way in potentially into the treatment um, toolbox, such as psychedelics and so on. So we have been doing a lot of work with that and imaging studies to see how are the effects on the brain of these drugs while the drugs are working acutely. So obviously psychedelics are a special kind of medication in the sense that they are given in this, when they're given in a full dose, that induce a psychedelic experience, then they're given a very rare occasion, so a few sessions, maybe even just a single session, at least in these research studies, and then you can measure the acute effect of this altered state of consciousness that they induce. You can also, if you test the psychedelic treatment more sort of as a therapy for a patient population, you might do the imaging before and at a later point in order not to interfere too much with the therapy session when the drug is working, which can be obviously quite distracting to have to, in the middle of a psychedelic experience, to walk in and out of a scanner and so on. So or to do it in the scanner. It's also noisy to be in an MRI scanner. It's not the most therapeutic environment. So therefore, in our therapy studies with these drugs, we do the brain imaging before and after. We can do some EEG during, and we are doing that in some studies, but we're doing a range of studies and have done some studies. I think some of the first studies in the modern era of psychedelics with depression, and also done some of the early imaging work with a range of these compounds. I mean, there are also other groups that have done some imaging work, even some decades ago, but very little. And we have then done some more studies trying to understand these drugs. We have done imaging with MDMA, LSD, DMT, psilocybin, and
Ketamine.
soon also. Yeah, ketamine we're doing at the moment. Ketamine is much more studied. So it comes from medicine, and it has been used and is being used in as an anesthetic. But it has been sort of redeveloped and retested and relicensed for treatment-resistant depression.
Mm.
So in a nasal spray formulation of one of the enantiomers of the original ketamine, but ketamine is in the good old version, can be used intravenously and is muscular, and is being used more and more for depression, and actually also tested for other indications such as addictions. So ketamine is already there, and probably used more and more as an alternative route for treatment of conditions such as depression. And then the psychedelics and MDMA are in their testing phase. MDMA very late. The phase 3 studies have been completed. So MDMA is going to be filed, the data, towards possible approval, maybe within the next year. So MDMA for post-traumatic stress, so not for depression. So yeah, and then psilocybin is being tested more and more in large-scale studies, going into phase 3 for depression. So psilocybin therapy. So that's a very different model for from SSRIs, for instance, where you have a single sessions with a drug that induces an altered state of consciousness, and together with psychological support, and in the future probably embedded into proper talking therapy, and that's probably how that's going to work out. It might take a generation to really after it's being approved, to actually fully integrate it into psychiatry practice in a lot of countries, because it's a bit of a change. You need specifically set up clinics and train therapists for that model, and then obviously more and more data should be and will be collected about its efficacy and safety. But so far in this phase, those models look very good.
Do you foresee that they could one day start replacing the antidepressants that are prescribed right now?
Again, I would call that a bold statement if I claim that. I don't think they will, or for that matter, maybe should. I mean, should they replace all talking therapies? Should all talking therapies have psychedelics? I mean, why would you? I mean, if people respond well to other treatments and are happy about those, don't have side effects, and they have a good effect of them, why would they? It could also be that some people, so a very, very crude way of sort of talking about differences between the psychedelic model and, let's say, SSRI, is that SSRI sort of might be more a bit of a dampening, taking some things away, some people feeling a bit blunted, which is a side effect, and that means that's sort of almost a lid being put on you to some degree. That might actually be quite soothing and fine for some people. Some people might find it more interesting to dive a bit deeper, maybe take the lid off. That is what the psychedelics might facilitate for those people. A little bit like, should CBT completely, as a cognitive behavioral therapy, should that replace any psychodynamic kind of therapy? why should it? I mean, we are all different. We are different people. We are curious in different ways. We are our psyche are different. Are different. Something might appeal and work better for some than others. If people want to try and restructure their thinking to improve in anxiety or depression, and don't want to dive deep or speak too much about earlier life and relations, maybe CBT is perfect. And whereas something more psychodynamic, diving deeper into, and psychedelics in a way represent a little bit that model versus SSRI, where SSRI is, it's a stupid comparison, but to put it very sort of that I don't think one should or will replace the other. Having extra very different tools in the
Mm.
psychiatric toolbox is just good, and great to have different treatment of options to offer people, and then it will be up to them through advice from whoever they're working with as a clinician and so on. But it's not that it's gonna be or should replace all existing tools that are in the same toolbox.
It's also very likely that there are certain people that will opt for SSRIs and certain people that would go for
Yeah.
the alternative therapies. What sparked your interest in researching these alternative therapies?
I mean, since the 80s, where fluoxetine came out, there's the first SSRIs. I mean, what has happened for a wide range of mental health conditions, not that much in terms of novel pharmacology. It has been in a way a bit modifications over the same original recipe, and again, there's a lot of people who don't respond. There's a lot of people who have side effects. There's a lot of people who struggle with coming out. There's a lot of reasons why there's sexual side effects. There are a lot of side effects that are maybe not always in focus. There's a lot of reason why it's worth trying to look for something else. And then you have these compounds that um, have been used wisely in a lot of cultures with beneficial effects reported. Obviously, a lot of that very anecdotal, because do you have the proper evidence to
Mm,
claim that? No, but it's still massively worth listening to and learning from and be inspired by. You even had in the Western world in the first era in the 1950s and 60s, maybe 40,000 people around that being treated with these therapies. And when you critically do meta-analysis of the old published data from these trials back then,
mm,
both for depression and alcohol addiction, for instance, that psychedelic treatment model overall looked promising and good. And then for a lot of reasons, it was then shut down and paused for decades. Now it's back, and we are testing again. We're applying
mm,
more stringent methodologies, although you can't do it perfectly. That's the issue. So that's a big challenge, that you can't placebo control it easily at all, if at all. So those are big challenges. However, what we see in these trials, I would say, they do convince me that it's definitely worth exploring even more and moving towards having them approved if the data hold. And nothing at this point seemed like it doesn't. So if anything, it would be unethical at this point to sort of stop this development. It needs to go further, and we need to see and scale it up and see whether it holds. And so you asked why. It's because the experience led, or at least altered state of consciousness involved in the treatment, having pharmacology induced psychological experiences it into the treatment model is interesting. It's a sort of a meeting point between pharmacology, psychiatry on one side, psychology on the other. The reports, what people's narratives in these studies are fantastically inspiring and interesting. So it's just a very rich field to work in. The neuroscience totally unexplored because
mm,
there were no scanners in the 1950s, 60s. So not to say that our tools, the brain scanners and the methods we use, they're perfect. Not at all. They are top of the iceberg, but it's still an interesting top of an iceberg to explore and try to understand our brain better. Consciousness. Here you have something that can
mm,
alter awake consciousness.
mm.
It gives you the ability to dive into some complex abstract questions about consciousness. So yeah, so there's a lot of reason why it's a rich field with these compounds to work in and apply imaging to.
These therapeutics are the threat to, big pharma, and I'm sure that had a big role to play in their discontinuation. Have you had any pushback to get these things to market?
So I don't think that big pharma would be. Maybe I'm naive. I don't see why they would be terrified, or why they would want to terrorize it, or obstruct it, sabotage it. I think, if the data holds, and now that is really going quite fast and being scaled up, if the data looks promising enough, then big pharma will just become very interested. And what they might do is they might buy all these more new startup kind of pharma companies in the psychedelic space. That might happen. Is that good or bad? I'm not going to say. I don't know. I mean, there are obviously potential risks and things that could go wrong or be unfortunate. Maybe some of the psychological model could be a bit lost, and that I don't think is a good idea. But I don't think that big pharma is out to get anyone, and it's not that it's also going to be a relatively expensive model. I mean, to have therapists in a room, it's basically enriching psychotherapy with pharmacology into it. It's not a cheap model. It's I think a beautiful and
Yeah,
very promising model.
it is.
But oh, is that challenging everything pharma is doing? I don't think it's just healthy that there might be some alternatives that actually have data to support that they can be an alternative. And if it's going to be strong enough, then big pharma is just going to go in and buy it all. I think. I don't know. So I don't think they're that scared, but they're probably more and more curious.